Spinal dysraphisms represent a critical subset of neural tube defects that demand expert NICU management and have profound implications for long-term neurologic outcomes. These conditions affect 1 to 2 in 1,000 pregnancies worldwide, making them the second most common birth defect after congenital heart defects. Understanding this frequency underscores why every neonatal provider must be proficient in their recognition and initial management. The fundamental classification divides these conditions into open and closed dysraphisms, each presenting distinct clinical challenges and urgency of intervention. Open dysraphisms, including meningocele and myelomeningocele, require prompt delivery, intensive care management, and urgent surgical intervention within 24 to 48 hours to prevent infection and preserve neurologic function. These exposed lesions result in severe neurologic impairment that directly correlates with the level of the defect, affecting motor and sensory function below the lesion site. Closed dysraphisms encompass a broader spectrum from Spina bifida occulta to complex Lipomyelomeningocele conditions. While often less severe initially and sometimes asymptomatic, they can cause significant neurologic deterioration through spinal cord tethering mechanisms. Critical NICU management priorities include infection prevention, surgical planning coordination, and vigilant monitoring for complications such as hydrocephalus, which develops in 60 to 80% of myelomeningocele patients, and Chiari II malformation symptoms. The functional prognosis correlates strongly with both the anatomic and functional level of the lesion, influencing ambulation potential, bladder and bowel function, and overall quality of life, making accurate early assessment essential for family counseling and care planning. Understanding normal neural tube formation is fundamental to grasping what goes wrong in spinal dysraphisms. Neural tube development occurs through 4 distinct overlapping processes that must proceed with precise timing. During week 3, gastrulation transforms the bilaminar embryonic disc into a trilaminar structure containing ectoderm, mesoderm, and endoderm. The notochord then signals ectodermal tissue to differentiate into neuroectoderm, forming the neural plate. Primary neurulation follows during weeks 3 to 4, where the neural plate folds inward and the edges contact each other in a zipper-like fashion. This closure is initiated at multiple sites and proceeds bidirectionally. The anterior neuropore closes around day 24, while the posterior neuropore closes approximately day 26. After primary neurulation, disjunction occurs where the neural tube separates from surface ectoderm, allowing mesoderm to migrate between them to form meninges, vertebrae, and paraspinal muscles. Finally, secondary neurulation during weeks 4 to 7 forms the caudal spinal cord through canalization of multipotent tail bud cells. Each of these processes represents a potential failure point leading to specific types of spinal dysraphisms. Each embryologic process failure creates distinct patterns of spinal dysraphisms, making understanding these mechanisms crucial for clinical recognition and management. Gastrulation defects result from a persistent neuroenteric canal that normally disappears, leading to complex malformations like split cord malformations and neuroenteric cysts where neural and gastrointestinal tissues remain inappropriately connected. Primary neurulation failure represents the most severe disruption, causing open spinal dysraphisms, including myelomeningocele and meningocele, when the neural folds fail to close properly. The sclerotomy cannot cover the exposed neuroepithelium, resulting in the characteristic bifid vertebral canal and exposed neural elements. Disjunction defects occur when separation between neural tube and surface ectoderm happens prematurely or incompletely. Premature disjunction allows fat to extend through the defect, creating lipomyelomeningocele, while incomplete disjunction results in dermal sinus tracts. Secondary neurulation defects affect the lower sacral and coccygeal regions, typically producing closed dysraphisms that don't open to the external environment but cause cord tethering due to faulty tissue separation. Multiple complex signaling pathways coordinate these processes, including planar cell polarity, sonic hedgehog, bone morphogenic protein, grainy head-like genes, and retinoid signaling pathways. Neural tube defect risk involves complex interactions between environmental and genetic factors, with some being modifiable through clinical intervention. The most significant modifiable environmental risk factor is folate deficiency, which affects neural tube closure mechanisms. Studies demonstrate that 70% of neural tube defects can be prevented through preconception folic acid supplementation. Vitamin B12 deficiency similarly impairs methylation pathways critical for neural development. Maternal diabetes mellitus increases risk through hyperglycemia-induced oxidative stress and altered gene expression. Specific medications pose teratogenic risks, particularly valproic acid and carbamazepine, which interfere with folate metabolism, and trimethoprim, which blocks folate synthesis. Environmental toxins like fumonisin, a fungal product found in corn-based products, have been linked to increased neural tube defect prevalence in certain populations. Inositol deficiency may compound folate insufficiency effects. Genetic susceptibility involves multiple genes, most notably MTHFR polymorphisms C677T and A1298C, which confer an 1.8-fold increased risk by reducing methylene tetrahydrofolate reductase activity and impacting folate metabolism. Approximately 200 genes are involved in neurulation, many affecting folate metabolism or transport. Families with one affected pregnancy face increased recurrence risk with each subsequent pregnancy, making genetic counseling and high-dose folate supplementation essential. Understanding the classification system for spinal dysraphisms provides the foundation for clinical decision-making, surgical planning, and prognostic discussions with families. This systematic approach divides these complex malformations based on clinically relevant anatomic features that directly impact management urgency and outcomes. The primary distinction between open and closed dysraphisms fundamentally determines the immediate clinical approach, as this classification reflects both the embryologic timing of the defect and the presence or absence of skin coverage. Open spinal dysraphisms represent the most urgent clinical scenarios, as neural elements are directly exposed to the external environment. Meningocele involves herniation of meninges through posterior vertebral arch defects. But crucially, the spinal cord remains properly positioned within the spinal canal with normal structure and function. These lesions are pedunculated, transilluminate well, and may be covered by cutaneous elements, generally carrying an excellent prognosis. Myelomeningocele, representing 50% of all neural tube defects, involves open spinal cord with herniated neural elements and demands immediate intervention. This category subdivides into Spina Bifida cystica, where exposed neural tissue is covered by a meningeal sac, versus Spina Bifida aperta, where the spinal cord is completely exposed. Both subtypes result in neurologic deficits below the lesion level and require urgent surgical closure within 24 to 48 hours. Closed spinal dysraphisms benefit from classification based on the presence or absence of a subcutaneous mass, which guides both diagnostic imaging decisions and surgical planning. Those with subcutaneous masses include Lipomyelomeningocele, where subcutaneous lipoma extends through fascia and dura to attach directly to the spinal cord, creating tethering. Remarkably, 48% of these patients remain neurologically intact at diagnosis, emphasizing the importance of early recognition before symptoms develop. Lipomyelocystocele and terminal or non-terminal myelocystocele represent increasingly complex variants involving persistent syringohydromyelic cavities. Closed dysraphisms without subcutaneous masses encompass several distinct entities requiring different management approaches. Diastematomyelia, or split cord malformation, involves the spinal cord splitting into two hemichords with separate ventral and dorsal roots, frequently associated with vertebral abnormalities like butterfly vertebrae. Neuroenteric cysts occur most commonly at the lower cervical, upper thoracic regions, and conus medullaris, often coexisting with split cord malformations due to shared gastrulation errors. Dermal sinus tracts, despite their benign external appearance, pose significant risks for life-threatening infections as epithelium-lined tracts terminate at the thecal sac. Abnormal phylum terminale, considered the mildest form, involves thickened phylum greater than 2 mm diameter with increased connective tissue or fat, potentially causing tethered cord syndrome. This classification system enables precise diagnosis, appropriate imaging selection, and tailored surgical timing, ultimately optimizing neurologic outcomes for each patient. Meningocele represents the more favorable form of open spinal dysraphism, distinguished by a crucial anatomic difference that significantly impacts prognosis. In meningocele, only the meninges herniate through the posterior vertebral arch defect, while the spinal cord maintains its normal position within the spinal canal. This preservation of spinal cord anatomy and nerve root structure results in normal neurologic function, making accurate recognition essential for appropriate family counseling. The lesions characteristically appear as pedunculated, fluid-filled sacs that transilluminate well and may be partially covered by cutaneous elements. Size varies considerably, but the underlying pathophysiology remains consistent. Posterior lumbar locations predominate, followed by sacral and thoracic sites, with anterior sacral variants also occurring. The generally excellent prognosis stems from the intact spinal cord and nerve roots, contrasting sharply with myelomeningocele outcomes. Importantly, Chiari II malformation is typically not present with meningocele. Unlike its near-universal association with myelomeningocele, this distinction has significant implications for long-term management, as the absence of associated hydrocephalus and brainstem dysfunction dramatically simplifies the clinical course and improves overall outcomes. Myelomeningocele constitutes the most significant and complex neural tube defect encountered in clinical practice, representing 50% of all neural tube defects and demanding immediate, expert intervention. Unlike meningocele, myelomeningocele involves herniation of actual neural elements, the spinal cord itself, through the vertebral defect, creating exposed neural tissue that determines both the urgency of management and long-term neurologic outcomes. The condition subdivides into two anatomic variants based on tissue coverage: Spina bifida cystica, where exposed neural tissue remains covered by a meningeal sac, and Spina bifida aperta, where the spinal cord lies completely exposed to the external environment. This anatomic distinction affects immediate management priorities, but not ultimate neurologic consequences. The overwhelming predominance of lumbar and lumbosacral locations, comprising 75% of cases, directly correlates with the high incidence of associated complications. Neurologic deficits invariably occur below the level of the lesion, creating patterns of motor and sensory loss that guide functional prognosis. The near-universal association with serious complications distinguishes myelomeningocele from other neural tube defects. Hydrocephalus develops in 80 to 90% of patients, requiring lifelong shunt management, while Chiari II malformation occurs almost universally in lumbar lesions, potentially causing life-threatening brainstem dysfunction requiring neurosurgical intervention. Accurate functional level assessment provides the foundation for prognostic discussions and rehabilitation planning in myelomeningocele patients. The functional level often differs from the anatomic level of the defect, as neural tissue viability within the lesion determines actual motor and sensory capabilities. Each spinal level corresponds to specific, testable motor functions and sensory distributions that create a systematic assessment framework. At T10, rectus abdominis function correlates with umbilical sensation. L1 level demonstrates hip flexion with anterolateral thigh sensation, while L2 adds hip adduction and anteromedial thigh sensation. The critical L3 level introduces knee extension capability with knee and shin sensation, a key milestone for ambulation potential. L4 function includes ankle dorsiflexion with dorsum of foot sensation, while L5 adds extensor hallucis longus function and sensation between the first and second toes. S1 level provides plantar flexion with plantar foot sensation, representing near-normal lower extremity function. The clinical pearl embedded in this assessment proves invaluable for rapid bedside evaluation. Presence of hip flexion suggests higher lumbar involvement, knee extension indicates mid-lumbar function, while isolated club feet typically signify low lumbar lesions. This systematic approach enables accurate prognostication regarding ambulation potential, wheelchair dependence, and rehabilitation needs, providing families with evidence-based expectations for functional outcomes and care planning. Open spinal dysraphisms represent medical emergencies requiring immediate, systematic intervention to prevent infection and preserve neurologic function. The critical 24 to 48-hour window demands precise execution of evidence-based protocols. Immediate care priorities center on infection prevention through sterile saline-soaked dressings that prevent desiccation while maintaining tissue viability. Prone or lateral positioning protects the exposed neural elements from trauma and allows optimal wound assessment. The NPO status prevents aspiration complications during urgent surgical evaluation and anesthesia administration. Antibiotic prophylaxis, typically ampicillin combined with gentamicin or cefotaxime, provides coverage against group B streptococcus and gram-negative bacteria, started within 1 hour of birth and continued at least 48 hours post-repair. Surgical closure within 24 to 48 hours represents the optimal standard, with most centers advocating closure within 24 hours when feasible. The surgical technique follows a systematic approach, neural placode closure to recreate the neural tube and potentially reduce tethered cord risk, followed by meningeal sac reconstruction, and finally skin closure. These goals, preventing infection, preserving existing neural function, and achieving durable anatomic closure, guide every aspect of perioperative management. Larger defects may require plastic surgery consultation for complex reconstruction, while careful attention to latex-free environments prevents sensitization in this high-risk population. Post-operative surveillance requires vigilant monitoring for 3 major complications that significantly impact long-term outcomes. Hydrocephalus develops in 60 to 80% of myelomeningocele patients, making early detection essential through daily head circumference measurements and weekly head ultrasounds. Classic signs include bulging anterior fontanelle, increasing head circumference, sunsetting eyes with visible sclera above the iris, dilated scalp veins, and systemic symptoms like vomiting and irritability. Progressive cases may demonstrate Cushing's triad with hemodynamic instability, indicating dangerously elevated intracranial pressure. Chiari II malformation symptoms reflect brainstem compression and lower cranial nerve dysfunction, manifesting as apnea and bradycardia that may require immediate neurosurgical intervention. Swallowing difficulties, gagging, weak cry, and inspiratory stridor indicate progressive hindbrain dysfunction with poor prognostic implications if symptoms persist after hydrocephalus treatment. Additional complications include wound dehiscence requiring surgical revision, local or systemic infections including life-threatening ventriculitis and meningitis, and the potential for future tethered cord syndrome as scarring develops around the repair site. The constellation of symptoms demands systematic assessment protocols with low thresholds for neuroimaging and neurosurgical consultation. Early recognition and prompt intervention for these complications directly correlates with preserved neurologic function and improved long-term developmental outcomes. Closed spinal dysraphisms represent a critical category of neural tube defects where the spinal cord malformation remains beneath intact skin coverage. These defects are subdivided based on whether a subcutaneous mass is present and affect 1 to 2 per 1,000 pregnancies worldwide. Unlike their open counterparts, these skin-covered lesions generally present with less immediate neurologic severity, and many patients may appear completely asymptomatic at birth. However, this benign appearance can be deceptive. The fundamental problem lies in spinal cord tethering, where abnormal tissue attachments prevent normal cord movement during growth, leading to progressive stretch injury. While surgical intervention can be appropriately delayed, unlike open dysraphisms, the presence of cutaneous stigmata provides crucial diagnostic clues. These surface markers occur in 4.2% to 7.2% of neonates with closed spina bifida and have high predictive value when 2 or more are present together. Recognition of these markers guides our risk stratification approach, determining which infants require immediate imaging versus observation. The key clinical insight is that early identification and prophylactic intervention may prevent irreversible neurologic deterioration that can develop as the child grows, and the spinal cord becomes increasingly stretched against fixed tethering elements. Spina bifida occulta represents the mildest form of spinal dysraphism, occurring when vertebrae split at the spinous process level while neural elements remain intact and properly positioned within the spinal canal. The vertebral defect is always covered by skin, distinguishing it from open lesions. The associated cutaneous markers serve as surface clues to the underlying bony defect. Midline dimples, hair tufts, skin discoloration changes, hemangiomatous lesions, and sinus tracts can all signal the presence of spina bifida occulta. The clinical challenge lies in recognizing that this apparently benign condition may remain asymptomatic for years or even decades before presenting with neurologic compromise. The risk emerges when Spina bifida occulta is associated with other closed dysraphisms that can cause cord tethering. This delayed presentation means that while immediate intervention isn't required, long-term vigilance is essential. Parents need counseling about potential future symptoms, including back pain, leg weakness, or bladder dysfunction that might develop later in childhood or adulthood. The presence of cutaneous stigmata, particularly when multiple markers occur together, increases the likelihood of associated tethering elements that may require eventual surgical intervention to prevent progressive neurologic decline. Cutaneous stigmata provide our roadmap for clinical decision-making in closed spinal dysraphisms, with evidence-based risk stratification guiding imaging decisions. High-risk findings mandate immediate MRI evaluation and include large hair tufts, hemangiomas greater than 2.5 centimeters, any subcutaneous mass, and midline dimples with cerebrospinal fluid leak. These markers carry significant predictive value for underlying spinal cord abnormalities, requiring neurosurgical evaluation. Intermediate risk findings require age-appropriate imaging. Spinal ultrasound for infants under 6 months, when ossification allows adequate visualization, and MRI for those over 6 months, when bony elements obscure ultrasonic assessment. Atypical dimples exceeding 5 millimeters in diameter or located more than 2.5 centimeters from the anal verge fall into this category, along with smaller hemangiomas under 2.5 centimeters and hypertrichosis. Low-risk findings typically don't require imaging but include simple dimples, hyperpigmentation or hypopigmentation changes, small melanocytic nevi, and port wine stains. This stratification system prevents both unnecessary imaging in low-risk cases and missed diagnoses in high-risk presentations. The key clinical pearl is that when parents express concern despite low-risk findings, spinal ultrasound can provide reassurance while avoiding radiation exposure from advanced imaging. Lipomyelomeningocele represents the most complex form of closed spinal dysraphism, typically occurring in the lumbar or sacral region where a subcutaneous lipoma extends through multiple tissue planes, the lumbosacral fascia, vertebral arches, and dura, to attach directly to the spinal cord as a tethering mass. The pathophysiology involves this lipomatous attachment, creating both congenital cord malformation and ongoing tethering risk. The subcutaneous fatty mass is usually evident at birth, enabling early diagnosis before neurologic symptoms develop. Remarkably, 48% of patients remain neurologically intact at initial diagnosis, highlighting the importance of early recognition and intervention. The 3 anatomic subtypes have distinct tethering patterns. Dorsal-type lipomas attach at the myelischisis level, where neural tissue fails to close properly. Transitional lipomas extend beyond this level down to the conus medullaris and may involve nerve roots. Caudal lipomas arise from the conus tip and often encase nerve roots completely. This anatomic complexity explains why patients face dual risks: the original congenital malformation plus potential retethering after surgical release due to scarring. Long-term complications include neurogenic bladder and bowel dysfunction, progressive orthopedic deformities, scoliosis development, and spasticity. Understanding these anatomic variants guides surgical planning and helps predict both immediate surgical risks and long-term retethering potential. Tethered cord syndrome describes progressive neurologic deterioration resulting from spinal cord stretch injury against fixed tethering elements, whether from filum terminale abnormalities or associated dysraphisms. The pathophysiology involves mechanical tension that impairs cord blood flow and neural function during normal growth. Clinical presentation rarely occurs in the neonatal period, instead developing insidiously as the child grows and cord tension increases. Early warning signs include atypical voiding patterns, particularly continuous dribbling, that should prompt immediate bladder volume measurement and urgent urologic consultation. Progressive weakness, delayed walking milestones, foot contractures, and persistent leg pain signal advancing cord dysfunction. Later presentations include gait abnormalities, progressive scoliosis, and worsening sphincter control. The critical clinical decision point is determining when neurologic deficits justify surgical intervention, as surgery carries significant risks. Tethered cord release procedures have complication rates between 10% and 30%, with a 5.8% risk of worse neurologic function post-operatively. Additionally, 10% to 20% of patients experience retethering, requiring repeat surgery. These statistics underscore why surgical timing depends on demonstrable neurologic progression rather than radiographic findings alone. Prophylactic intervention may prevent deterioration, but the irreversible nature of some neurologic damage means early recognition and appropriate referral timing are crucial for optimal outcomes. Split cord malformation, also known as diastematomyelia, represents a fascinating embryologic anomaly where the spinal cord divides into two distinct hemichords, each maintaining its own complete set of ventral and dorsal nerve roots. This malformation results from errors in gastrulation when the persistent neuroenteric canal fails to disappear normally. The classification system distinguishes between lesions encased in a single dural sac versus those with split dural sacs at the dysraphism level. A crucial diagnostic feature is the potential presence of fibrous or bony septum between the hemichords, which creates additional tethering risk. The anatomic complexity extends beyond the cord itself, with frequent association of low-lying conus medullaris and thickened filum terminale contributing to tethering syndrome. Vertebral abnormalities are remarkably common, including butterfly vertebrae, widened spinal canals, pedicle fusion, and vertebral body segmentation failures. These bony changes often provide radiographic clues to the underlying neural malformation. Split cord malformations rarely occur in isolation, frequently coexisting with other dysraphisms and neuroenteric cysts due to their shared embryologic origins. Understanding this association is critical because neuroenteric cysts occur most frequently at the lower cervical, upper thoracic regions, and conus medullaris. These cysts can be extradural or intradural, and when intradural, may be anterior, posterior, or within the spinal cord itself, complicating surgical planning and increasing operative risks. These two distinct closed dysraphisms exemplify how different embryologic failures can create life-threatening complications, despite their skin-covered, benign appearance. Neuroenteric cysts arise from persistent neuroenteric canal formation during gastrulation errors, when the temporary dorsal-ventral connection fails to disappear appropriately. Their anatomic distribution is highly predictable, occurring most frequently at the lower cervical and upper thoracic regions and at the conus medullaris. The cysts demonstrate remarkable variability in location, existing as extradural or intradural lesions, and when intradural, may be anterior, posterior, or within the spinal cord parenchyma itself. Their close association with split cord malformations reflects their shared gastrulation origin, making combined lesions common. Dermal sinus tracts present a different but equally serious threat, involving epithelium-lined tracts of variable depth that usually terminate in or on the thecal sac. These tracts typically occur at the neuraxis extremes and create direct communication pathways for bacteria to track into the cerebrospinal fluid space. The resulting risk of life-threatening meningitis makes dermal sinus tracts true neurosurgical emergencies requiring timely intervention despite their deceptively benign external appearance. Associated inclusion cysts, including dermoid and epidermoid formations, can develop along these tracts, creating additional mass effect and infection risk. Both conditions can be associated with tethered cord syndrome and diastematomyelia, emphasizing the need for comprehensive imaging evaluation when either is suspected. Chiari II malformation represents one of the most significant associated anomalies in Myelomeningocele, occurring almost universally with open neural tube defects and fundamentally altering patient management. The pathophysiology involves a characteristically small posterior fossa with complex hindbrain malformation resulting from altered cerebrospinal fluid dynamics during fetal development. The anatomic features create a distinctive imaging pattern including cerebellar vermis herniation below the foramen magnum, the pathognomonic beaked tectum appearance, and abnormally low-lying tentorium and transverse sinuses. This constellation of findings reflects the crowded posterior fossa that forces normal structures into abnormal positions. The clinical manifestations directly correlate with anatomic compression and dysfunction of critical brainstem structures. Lower cranial nerve dysfunction presents as the most concerning feature. manifesting as apnea episodes, swallowing difficulties, gagging with feeds, and characteristically weak cry. These symptoms reflect compression of cranial nerves 9, 10, and 12, which control swallowing, vocal cord function, and respiratory drive. The severity of symptoms determines the need for neurosurgical intervention, with posterior fossa decompression required when conservative management fails to control life-threatening apnea or severe feeding dysfunction. Understanding this malformation is crucial because symptoms can worsen after myelomeningocele closure when cerebrospinal fluid dynamics change, and untreated hydrocephalus can exacerbate Chiari II symptoms through increased downward pressure, creating a neurosurgical emergency requiring immediate intervention. Hydrocephalus represents one of the most significant complications in neural tube defects, occurring in 60% to 80% of infants with myelomeningocele and fundamentally altering their clinical course and long-term prognosis. The pathophysiology involves obstructive cerebrospinal fluid dynamics, where normal absorption is impaired while production continues at the typical rate of 0.3 milliliters per minute. This imbalance creates progressive ventricular enlargement that often manifests after myelomeningocele closure when cerebrospinal fluid can no longer decompress into the spinal sac. The clinical presentation in neonates differs significantly from older children due to open cranial sutures that allow head expansion rather than immediate signs of increased intracranial pressure. Early warning signs include rapid head circumference growth, tense and bulging anterior fontanelle, and characteristic sunsetting eyes where the infant's gaze appears fixed downward. Additional concerning features include dilated scalp veins, reflecting increased venous pressure, persistent irritability, vomiting episodes, and in severe cases, hemodynamic instability manifesting as Cushing's triad with bradycardia, hypertension, and altered respiratory patterns. The management approach centers on ventriculoperitoneal shunt placement, which creates an alternative drainage pathway from the lateral ventricles to the peritoneal cavity where cerebrospinal fluid can be absorbed. This intervention requires lifelong monitoring for shunt malfunction, infection, or obstruction. The striking contrast with closed spinal dysraphisms is important to recognize, as hydrocephalus rarely occurs in these conditions, underscoring the different pathophysiologic mechanisms involved in open versus closed neural tube defects. Prenatal detection of neural tube defects relies on a sophisticated, multimodal approach that has revolutionized early diagnosis and family counseling. Maternal serum screening using alpha-fetoprotein serves as the initial screening tool with optimal timing between 16 and 18 weeks gestation when levels normally increase steadily. The typical cutoff of 2.0 to 2.5 multiples of the median provides 90% specificity for open spina bifida cases and 100% sensitivity for anencephaly detection. However, elevated alpha-fetoprotein can occur with misstating, multiple gestations, or other fetal abnormalities including gastroschisis and omphalocelie, necessitating confirmatory testing. Ultrasonographic evaluation represents the gold standard for direct visualization, with experienced sonographers achieving 97% sensitivity and 100% specificity for open neural tube defects. The pathognomonic ultrasound findings include the lemon sign, where frontal bone scalloping creates a lemon-shaped skull appearance, and the banana sign, reflecting cerebellar compression and abnormal curvature. Associated findings such as ventriculomegaly, Arnold-Chiari malformation features, and direct visualization of the spinal defect help determine lesion level and severity. Fetal magnetic resonance imaging provides superior soft tissue contrast that enhances evaluation of associated brain malformations, particularly useful for assessing posterior fossa abnormalities and determining prognosis. The ability to visualize corpus callosum development, cortical migration patterns, and brain stem anatomy helps predict neurodevelopmental outcomes. Chromosomal analysis through amniocentesis excludes associated genetic syndromes, as neural tube defects can occur with trisomies 13 and 18. This comprehensive diagnostic approach enables informed decision-making about pregnancy management, delivery planning, and postnatal care coordination. Folate supplementation represents one of the most successful primary prevention strategies in modern medicine, with evidence demonstrating that 70% of neural tube defects can be prevented through periconceptional folic acid administration. The standard recommendation for all women of reproductive age involves 400 micrograms daily of folic acid, beginning before conception and continuing through the first trimester when neural tube closure occurs between 18 and 28 days after conception. This timing is critical because many women don't realize they're pregnant during this vulnerable period when neurulation is actively occurring. High-risk women require substantially higher doses of 4 to 5 milligrams daily, including those with previous neural tube defect pregnancies, maternal diabetes mellitus, or those taking anticonvulsant medications like valproic acid or carbamazepine that interfere with folate metabolism. The mechanism involves folate's essential role in DNA synthesis and methylation reactions required for proper neural tube closure, with deficiency disrupting these fundamental cellular processes. The population-level impact has been remarkable, with prevalence rates dropping dramatically following public health interventions. England and Wales experienced a decline from 6 per 1,000 births in 1960 to 1 per 1,000 births by 1961-1990, reflecting combined effects of folate supplementation and prenatal diagnosis with selective termination. Food fortification programs have proven highly effective, with mandatory fortification of grain products in many countries providing population-wide protection. Emerging research suggests inositol may provide additional benefit beyond folate alone, potentially offering enhanced protection through complementary metabolic pathways. The success of this intervention demonstrates how understanding embryologic mechanisms can translate into practical preventive strategies that dramatically reduce birth defect incidence. The management of Myelomeningocele study, known as the MOMS trial, represents a landmark investigation that fundamentally changed our understanding of fetal surgery for neural tube defects. This randomized controlled trial of 183 patients compared prenatal repair before 26 weeks gestation with standard postnatal repair, establishing new evidence for fetal intervention benefits. The primary endpoints focused on clinically meaningful outcomes, including fetal or neonatal death, need for cerebrospinal fluid shunting at 12 months, and neurodevelopmental function at 30 months. The results demonstrated compelling advantages for prenatal repair, with only 40% of fetal surgery patients requiring shunt placement compared to 82% in the postnatal group. Additionally, prenatal repair showed improved mental and motor development scores at 30 months, along with reduced hindbrain herniation severity and enhanced ambulation potential. However, these benefits came with significant maternal risks that led to early trial termination despite efficacy findings. Fetal surgery carries substantial maternal morbidity, including increased risk of preterm delivery, uterine dehiscence, and potential uterine rupture in subsequent pregnancies. The specialized nature of these procedures limits availability to a few expert centers, restricting access for many families and creating geographic disparities in care options. Current standard of care remains postnatal repair within 24 to 48 hours after birth, focusing on preventing infection and further neurologic deterioration through prompt surgical closure. Emerging fetoscopic techniques offer promise for reducing maternal morbidity while preserving fetal benefits, with early reports showing encouraging results but requiring further validation. The future of fetal intervention continues evolving as surgical techniques advance and long-term outcome data mature, requiring careful consideration of risks and benefits for each individual case. Understanding functional outcomes requires recognizing that the anatomical level of the spinal lesion directly determines neurologic function and long-term prognosis, creating a predictable pattern that guides family counseling and care planning. Thoracic-level lesions represent the most severe form, typically producing complete paraplegia with generally poor overall prognosis and significantly increased mortality risk due to the extensive neurologic impairment affecting respiratory muscles, trunk stability, and all lower extremity function. These children face the greatest challenges with mobility, requiring wheelchair dependence and often experiencing respiratory complications that can be life-threatening. High lumbar lesions at the L1 to L2 level preserve hip flexion function, allowing patients to lift their thighs but lack knee extension and all distal motor control. These children typically become wheelchair dependent for mobility, though they may achieve some therapeutic standing with extensive bracing. Urologic dysfunction remains significant at this level, requiring comprehensive bladder management throughout life. Mid-lumbar lesions affecting L3 to L4 levels represent a crucial functional threshold because preserved knee extension enables community ambulation with braces and assistive devices. These patients can often achieve meaningful walking function, though they may require crutches or walkers and have variable bladder control that improves compared to higher lesions. Low lumbar and sacral level lesions offer the most optimistic prognosis, with preservation of motor function allowing independent ambulation that may require minimal or no assistive devices. Bladder and bowel control shows marked improvement at these levels, though some degree of neurogenic dysfunction typically persists, requiring ongoing monitoring and management strategies. Caring for individuals with neural tube defects requires understanding that these conditions affect multiple organ systems simultaneously, creating complex medical needs that persist throughout life and require coordinated, multidisciplinary management. Neurologic complications extend far beyond the initial spinal defect, encompassing shunt-related problems that can include malfunction, infection, or over-drainage requiring repeated surgical interventions. Tethered cord syndrome may develop or worsen over time as growth places increasing tension on scarred spinal tissue, potentially causing progressive neurologic deterioration. Seizure disorders can emerge, particularly in patients with associated brain malformations, while learning disabilities affect educational achievement despite typically normal cognitive potential. Orthopedic complications develop progressively due to muscle imbalances and abnormal forces on the developing skeleton. Scoliosis and kyphosis commonly worsen during growth spurts, potentially requiring surgical intervention to prevent respiratory compromise. Hip dislocations occur due to muscle imbalance around the joint, while foot deformities, including club foot, require ongoing orthopedic management. Decreased sensation increases fracture risk because patients may not recognize trauma, leading to pathologic fractures that heal poorly. Urologic management remains central to long-term health, as neurogenic bladder predisposes to frequent urinary tract infections that can progress to serious kidney damage. Clean intermittent catheterization becomes a lifelong necessity for most patients, requiring family education and patient independence training. Gastrointestinal complications center on neurogenic bowel dysfunction, causing chronic constipation and fecal incontinence that significantly impacts quality of life. Structured bowel management programs help establish predictable elimination patterns. Additionally, latex allergy develops in up to 70% of Spina Bifida patients due to repeated medical exposures, requiring strict latex avoidance protocols. Skin breakdown risks increase due to decreased sensation and moisture from incontinence, demanding vigilant skincare and pressure relief strategies. Assessing outcomes in neural tube defects requires moving beyond purely medical measures to understand how these individuals function in daily life and perceive their own well-being, which research shows can be surprisingly positive despite significant physical challenges. Functional measures examine activities of daily living, including feeding, dressing, bathing, and toileting independence, which directly impact family dynamics and individual self-esteem. Mobility and ambulation capabilities determine participation in community activities, school engagement, and peer relationships, while communication abilities remain typically intact, preserving important social connections. Educational outcomes present a complex picture because cognitive function usually develops normally, yet learning disabilities may emerge due to associated brain malformations or hydrocephalus complications. Many children require educational support services, not due to intellectual impairment, but because of attention deficits, visual motor integration problems, or executive function difficulties that interfere with academic performance. Special education needs may include accommodations for physical limitations, assistance with catheterization, or modified physical education programs. Social integration represents perhaps the most crucial determinant of long-term satisfaction, as peer relationships during childhood and adolescence shape adult social skills and self-perception. Recreation participation often requires adaptations, but enables important social connections and physical fitness maintenance. Employment potential in adulthood depends more on educational achievement and social skills than on physical limitations, with many adults achieving meaningful careers and financial independence. Research demonstrates that most adolescents and young adults with spina bifida report acceptable quality of life despite their disabilities, finding satisfaction in relationships, achievements, and personal growth. This finding challenges assumptions about disability and highlights the importance of focusing on capabilities rather than limitations when counseling families and planning interventions. When counseling families facing a spina bifida diagnosis, your role extends far beyond delivering medical facts. You're providing the foundation for informed decision-making during an emotionally challenging time. The prognosis conversation must be anchored in the functional level of the lesion, not just anatomical location. A thorough neurologic assessment, examining spontaneous movement, response to sensation, and deep tendon reflexes, provides more accurate prognostic information than MRI alone. Present associated anomalies with specific data. Hydrocephalus develops in 60 to 80% of Myelomeningocele cases, requiring shunt placement. Chiari II malformation occurs in most cases and can present with apnea, stridor, and feeding difficulties requiring monitoring. When discussing surgical timing, emphasize that closure within 48 hours prevents infection and optimizes neurologic outcomes. Decision factors for surgical closure require balancing multiple variables. Technical feasibility depends on lesion size and location, while prognosis for ambulation correlates with functional motor level. Hip flexion suggests higher lumbar involvement, knee extension indicates mid-lumbar, and isolated clubfoot suggests low lumbar lesions. Family resources and attitudes significantly impact long-term outcomes. Connect families with spina bifida associations and ensure multidisciplinary team involvement from the start. This establishes the comprehensive care model they'll need throughout their child's life, making the transition to complex medical management more manageable for overwhelmed parents. Discharge planning for spina bifida requires orchestrating complex, long-term care that begins in the NICU. Medical home establishment isn't just scheduling appointments, it's creating a coordinated system where your multidisciplinary team communicates effectively with primary pediatric care and specialists. The pediatric neurosurgeon, urologist, orthopedist, and developmental pediatrician must have established protocols for ongoing care. Equipment needs assessment requires specific planning. Shunt monitoring equipment for home use, appropriate mobility devices based on functional level, and bladder management supplies must be arranged before discharge. Latex allergy prevention is critical. These children have high sensitization rates, requiring latex-free environments from birth. Family education focuses on recognizing emergencies. Shunt malfunction signs include irritability, vomiting, lethargy, and changes in head circumference. Skincare and positioning prevent pressure sores, particularly important given altered sensation below the lesion level. Infection prevention protocols matter because these children face increased susceptibility to urinary tract infections and wound infections. Early intervention referrals should be in place before discharge. Physical therapy addresses motor development and contracture prevention, while occupational therapy focuses on adaptive skills. Special needs planning includes educational advocacy and developmental assessments. This comprehensive discharge approach significantly improves long-term outcomes and reduces emergency department visits during the vulnerable post-discharge period. Closed dysraphisms present fundamentally different surgical decision-making than open defects. Unlike myelomeningocele, requiring urgent closure, closed defects allow careful timing and patient selection. Surgery becomes indicated when progressive neurologic symptoms develop or when tethered cord syndrome presents with functional deficits. Not all lesions require intervention. Many remain asymptomatic throughout life. The key distinction is that these children aren't exposed to external environment risks, allowing surgical timing optimization. Progressive neurologic decline, new-onset bowel or bladder dysfunction, motor weakness, or pain patterns suggest tethered cord requiring intervention. However, surgery carries significant risks that must be weighed against potential benefits. Surgical goals include releasing tethered cord, removing tethering lesions like lipomas or dermoid cysts, preserving neural elements, and preventing retethering. The complexity varies considerably. Simple film terminally division has lower morbidity than complex Lipomyelomeningocele repair requiring neural element manipulation. Timing becomes critical in surgical planning. Unlike open defects requiring emergency closure, closed dysraphisms can be delayed for optimal patient condition and surgical expertise. However, delaying too long after symptom onset may result in irreversible neurologic damage. Complication rates range from 10 to 30%, including neurologic decline, incomplete wound healing, infection, and retethering risk of 10 to 20%. These sobering statistics require careful risk-benefit analysis with families when symptoms are mild or equivocal. Latex allergy represents a critical safety consideration in Spina Bifida care, with these patients facing dramatically elevated risk compared to the general population. The evidence is compelling. Spina Bifida patients develop latex allergy at rates up to 20 times higher than typical individuals, primarily due to repeated exposures through multiple surgeries and frequent catheterizations throughout their lives. The pathophysiology involves sensitization through repeated mucosal and tissue contact with latex proteins during medical procedures. Each surgical intervention, urological procedure, and catheterization creates additional opportunities for sensitization. This cumulative exposure risk makes primary prevention absolutely essential rather than reactive management. Primary prevention requires establishing latex-free environments from birth. This means latex-free delivery rooms, NICU environments, and all subsequent healthcare encounters. Hospital protocols must ensure latex-free gloves, equipment, and medical devices. Even minimal exposure can trigger sensitization in these high-risk patients. Clinical manifestations range from localized contact dermatitis to life-threatening anaphylaxis. The progression can be unpredictable. Patients may initially show only mild skin reactions, but later develop severe systemic responses. Family education becomes crucial for maintaining latex avoidance in home environments, reading product labels, and recognizing early warning signs. Medical alert documentation must accompany these patients throughout their healthcare journey. This includes bracelets, medical records notation, and clear communication with all healthcare providers. Prevention through primary prophylaxis has proven remarkably effective when implemented consistently from birth. The landscape of neural tube defect research is rapidly evolving across multiple innovative frontiers. Stem cell therapy represents one of the most promising areas, with mesenchymal stem cells showing particular potential for neural regeneration. These cells demonstrate anti-inflammatory and immunosuppressive properties that mediate anti-apoptotic effects while promoting neuroregenerative functions. Umbilical cord blood contains several stem cell populations, including mesenchymal stem cells, endothelial progenitor cells, and mononuclear cells. Clinical trials using autologous umbilical cord blood have demonstrated both feasibility and safety, with Phase 2 studies showing trends toward improved neurodevelopmental outcomes. The therapeutic window for stem cell therapy extends well beyond the acute injury phase, targeting secondary and tertiary injury mechanisms. Tissue engineering advances focus on biomaterial development and improved closure techniques. These approaches aim to create better scaffolds for neural tissue repair and enhanced wound healing. Genetic research continues expanding our understanding of the complex interplay between environmental and genetic risk factors, with methylene tetrahydrofolate reductase polymorphisms showing 1.8-fold increased neural tube defect risk. Improved fetal surgery techniques emphasize less invasive approaches and better patient selection criteria. The landmark management of myelomeningocele study demonstrated significant benefits of prenatal repair, including reduced hindbrain herniation and decreased need for shunting. Neuroprotection strategies investigate preventing secondary injury through various mechanisms. Melatonin shows promise as an adjunct therapy, with neuroprotective benefits demonstrated through anti-apoptotic and antioxidative properties. These research directions collectively aim to optimize long-term neurological outcomes for affected patients. Recognition skills form the foundation of effective spinal dysraphism management. Cutaneous markers of closed dysraphisms include dimples, lipomas, hair patches, or skin discoloration overlying the spine. Understanding risk stratification helps determine which patients require immediate imaging versus observation. Any suspicion of tethered cord or associated anomalies warrants prompt neurological consultation. Management of open defects constitutes a surgical emergency requiring closure within 24 to 48 hours to prevent infection and preserve neurological function. Immediate care involves sterile saline dressing application, prone positioning to protect the exposed tissue, and prophylactic antibiotic administration within 1 hour of birth. Coverage typically includes ampicillin plus gentamicin or cefotaxime to address Group B streptococcus and gram-negative organisms. Close monitoring for hydrocephalus development is essential, as 80 to 90% of myelomeningocele patients will require shunting. Daily head circumference measurements and weekly head ultrasounds help detect early signs. Chiari II malformation symptoms, including apnea, bradycardia, or feeding difficulties, require immediate attention and may indicate need for posterior fossa decompression. Long-term planning requires understanding that functional outcomes correlate directly with lesion level. Higher lesions result in more significant motor and sensory deficits, affecting ambulation potential and bladder function. The multi-system approach must address orthopedic, urological, and developmental needs. Early intervention programs optimize developmental outcomes despite neurological limitations. Family support and education prove crucial throughout the care continuum. Parents need comprehensive information about expected outcomes, surgical procedures, and long-term care requirements. Connecting families with support groups and community resources helps manage this complex lifelong condition. Prevention advocacy represents our most powerful tool. Periconceptional folate supplementation prevents 60 to 70% of neural tube defects. Prenatal diagnosis enables care planning and counseling, allowing families to make informed decisions and prepare for specialized delivery and immediate postnatal care. Spinal dysraphisms represent the second most common birth defect after congenital heart disease, affecting 1 to 2 per 1,000 pregnancies worldwide, and requiring sophisticated NICU management expertise. The embryologic understanding of primary neurulation, disjunction, and secondary neurulation directly guides our classification systems and treatment approaches, helping clinicians predict outcomes and plan interventions. Open dysraphisms create surgical emergencies demanding closure within 24 to 48 hours to prevent meningitis and preserve remaining neurological function. The urgency stems from direct exposure to environmental pathogens and ongoing neural tissue damage. Prophylactic antibiotics and sterile wound management significantly reduce infection risk when combined with timely surgical intervention. Closed dysraphisms allow more deliberate timing, but require careful monitoring for tethered cord syndrome development. These lesions may appear deceptively benign, but can cause progressive neurological deterioration if left untreated. Recognition of cutaneous markers guides appropriate imaging and specialist referral decisions. Associated anomalies including hydrocephalus and Chiari II malformation require ongoing surveillance throughout the NICU stay and beyond. Hydrocephalus develops in 80 to 90% of Myelomeningocele patients, while Chiari II symptoms can manifest as life-threatening brainstem dysfunction requiring immediate intervention. Functional outcomes show strong correlation with lesion level, with higher lesions producing more significant motor and sensory deficits. This relationship helps families understand prognosis and guides rehabilitation planning. The multidisciplinary team approach addresses complex needs spanning neurosurgery, orthopedics, urology, and developmental medicine. Prevention through periconceptional folate supplementation represents one of public health's greatest successes, preventing 60 to 70% of cases when implemented properly. This intervention alone has dramatically reduced neural tube defect prevalence in countries with folate fortification programs. Family support and education remain crucial throughout the entire care journey, from initial diagnosis through long-term management. These families face complex medical decisions and lifelong care coordination challenges requiring comprehensive support systems and community resources.